had total of we have a total of webinar registrants as of last night, 172. And questions we ask you, have you received COVID-19 vaccines? And 160 of you answered yes, and 7 no, and no response is 5. Now, the reasons who answer that were given by the respondents that said no, it says that not available, limited vaccines, and they are from the Philippines. One respondent said got COVID, and 2 of them no reason. And there was one of our participants or the registrant was below 12 years old. So he or she could not get the vaccine. Another question is, would you recommend the COVID-19 vaccines to your family and friends? 165 respondents said yes, 2 said no, and 5 no response, and no reasons were given. COVID-19 registrants questions, just to summarize it, it's about COVID-19 and Delta variant, which our speakers will talk about it today. Vaccine efficacy, vaccine safety, vaccine booster, back to school, and vaccine strategy. So hopefully our panel of speakers will discuss all these topics, and you can ask questions later. Just want to share too about the American Nurses Association did a COVID vaccine facts survey for nurses, and 4,912 nurse respondents, and I segregated the Filipino nurses, and 223 Filipino nurses actually participated in the survey. And the questions that were asked, how do you feel the amount of information you are getting on COVID-19 vaccines? And at least 72% enough information, 17% not enough information.
Sorry, Ida, can you unmute?
And actually, 11% said that, had too much information. And this information you can find on COVID vaccines, factsfornurses.org. And I just want to share you some other information in terms of sources of COVID-19 vaccine information. We all have the CDC and IAs from your colleagues, employer, friends, families, professional organizations, social media, and there's a lot in social media, World Health Organization. And these are some of the questions too some of the answers from the questions like ongoing concerns and their questions. And it kind of, echoes most of the questions that you all had entered, and also your concerns when you registered. And now I have Lourdes Carriaga to introduce our panel of speakers. Lourdes.
Thank you, Ida. Good morning, everyone. I'm here to present the expert panel of speakers that we have for this webinar. So excited to have these dear colleagues who are just within the Washington, D.C. neighborhood, who are actually very knowledgeable about the COVID vaccines and who could really help us out navigate our informational web networks that we are getting to help us out with this new re-entry in the new normal. The speakers are going to be introduced according to their time of presentations. I'm here to present Dr. Kathy Ferrer, who's the attending physician in the Pediatric Hospital Medicine and Infectious Disease Divisions at Children's National Hospital. She's the education lead for its global health initiatives. She serves as a clinician for the Children's National Special Immunological Clinic, caring for children with perinatally and horizontally acquired HIV. She previously served as a medical director at the Baylor College of Medicine, Bristol Myers Squibb Children's Clinical Center of Excellence in Lesotho, where she assisted with a scale-up of pediatric HIV care and treatment for the country. When the COVID pandemic hit in March 2020, Dr. Ferrer was called upon to lead the occupational health response at Children's National. Along with a multidisciplinary team, she oversaw the triage, testing, isolation, and quarantining of Children's National Hospital employees and was integral in the COVID vaccine rollout in Washington, D.C. Catherine Graham is an occupational health nurse at the Children's National Hospital in Washington, D.C. She is currently a member of the COVID response team at Children's National, administering COVID vaccinations, performing employee testings, and conducting telephone triage for COVID symptoms and exposures. Kat embarked on her nursing career 6 years ago after receiving Bachelor's of Nursing from Chamberlain College of Nursing, as inspired by her mother's 35+ year career as an ICU nurse. Kat has a combined 13 years of healthcare experience from a variety of fields, including dialysis, telemetry, and the operating room. She was born in Malolos, Bulacan, Philippines, and migrated to the US when she was 5 years old and continues to fluently speak her native tongue of Tagalog. She is a proud member of the Philippine Nurses Association of Metro DC. Dr. Nathalie Quillon is a medical director at Children's National Medical Center in Washington, D.C. She has over 25 years of medical practice and has been named as one of the top doctors in Northern Virginia for 2021. Dr. Quillon is the current president of the Philippine Medical Association of Metro Washington, D.C. She received her Bachelor of Science degree from the University of the Philippines, earned her medical degree from University of the East College of Medicine in 1988. Her internship and residency programs in pediatrics were completed at the University of Texas Medical School at Houston in 1992 and 1994, respectively. Her fellowship program in pediatrics was from University of Massachusetts Memorial Medical Center in 1996. Dr. Quillon is certified in pediatrics by the American Board of Pediatrics. I'm very proud to have known Dr. Quillon, as she is the president of the Philippine Medical Association of Metro Washington, D.C., and she was a strong proponent of addressing vaccination hesitancy in the Filipino-American community in D.C., and we were strongly collaborating since the start of this year in trying to ensure that the community addresses vaccination hesitancy right on. I am here to present these three speakers and now ready to present the webinar to them to help them out, roll this out now. Thank you.
Thank you, Lourdes, for that very kind and generous introduction. I'm going to go ahead and share my screen. Let's see, this should work. There we go. All right, and you should be able to see it now.
Yes, thank you.
Thank you very much for putting together this webinar. And again, I know that in the beginnings, we really wanted to make it a town hall format. So really this first 20 minutes that I'll be discussing is really as a background and as a way to introduce, then the key part will be the questions and answers, where again, hopefully you will then be able to unmute and also send questions through the chat so that we can basically get everything that you've been curious about or wondering about with regards to COVID, the Delta variant, and boosters, and get those questions answered. Again, also a big shout out to my mom, who I see on the webinar. She is really the inspiration for me in terms of going into medicine, as well as my father. My mom's has been a nurse for 30, 40 years or so, but she is now retired. So she's been enjoying the benefits of retirement. And so with that, I'm going to go ahead and move on again, so that I respect your time. And I have about 20 minutes. Really, we did get and acknowledge many questions that were sent ahead of time when you registered the first time. And really, we wanted to focus on, number one, a situational update regarding the Delta variant and its impact. We'll review vaccines, how they work and compare effectiveness. And then lastly, we'll discuss what's the evidence behind a third vaccine dose. Again, it's very reassuring that we have a very highly vaccinated group right now. And it's great to hear this because we know that vaccines are effective and we know that they're safe. So I know I'm already preaching to the choir. And later on, Kat, who's one of my esteemed colleagues at Children's National, will be giving you more tips as to how you can then use the knowledge that you're gaining here and then hopefully convince your colleagues, your family, your friends to also get vaccinated. And so with that, just quickly in terms of the situational update, we are now in what we are calling our fourth surge. So 1, 2, 3, and 4. We know that the winter was difficult in the United States where we had the highest number of cases per day, almost getting up to 300,000 on some days. But unfortunately, we are heading back in that direction. The nadir of our epidemic here in the US was really in June, at the end of June. It was the same last year where the lowest number of cases we were seeing was in June. And basically after July 4th, as people start getting together again, it started to skyrocket. As well as given the Delta variant, that it certainly had an impact in basically causing us to again have a surge despite being fully vaccinated. And so as you can see, in terms of the number of fully vaccinated people in the United States, we're at 51%. So a majority of us are fully vaccinated. At least 60% have had one dose. And we see that impact mostly in deaths and hospitalizations. And so in terms of deaths is because we have been able to roll out the vaccine as opposed to many other countries, is that again, we know the vaccine is effective in preventing death, preventing hospitalization, and preventing severe disease. And so we've seen that impact here, but we're still seeing this surge because of, again, unvaccinated people and also the Delta variant, which we'll get into a little bit more later. And as you can see, when you look at the entire United States, all of this is now red. So, you know, when I had given this talk in May, it was probably a lot more orange and yellow and blue, but clearly the Delta variant is responsible for the increase in cases throughout the country, particularly hardest hit places where there's low vaccination rates in the South. Mississippi, Arkansas, obviously Florida, and Texas. And California is also seeing a different type of epidemic than it did earlier in the previous waves, where there are more people getting infected and more people getting sick because of the Delta. Again, looking at it from a global perspective, as you can see, they're also had their increase in the holidays, December and January, but then this really represents all of the cases that were contributed by India when they had their big surge, and essentially attributed to the Delta variant, where they only had a few % of their population vaccinated, and Delta really took a toll, and hence globally that makes up for this big surge here. And as you can see, again, the rest of the world, as that Delta variant spread worldwide, also seeing a surge in cases. Hotspots, again, the United States has not done well with this epidemic at all in terms of looking at the daily cases per 100,000. And so this is a general number that we use to basically compare numbers between countries and between counties and within the United States. And if you remember, back in the summer of 2020, once we were getting above 10 cases per 100,000, that's when we were getting worried and we're saying, oh, we might have to have travel bans, quarantines, and lockdowns. But as you can see, we are way above that now. But thankfully, we do have the vaccine, so hopefully that will decrease the necessity of having lockdowns like we did last summer. Now, shifting focus to the Philippines. Unfortunately, the Philippines right now is in its peak and it's still rising. I like using this Reuters for looking at global trends, just because it looks at not only what's happening now, but where it's going. Unfortunately, as I mentioned before, remember that benchmark of 10 is when I start getting worried. The Philippines right now is at 87 infections per 100,000 people. So that is very worrisome. Places in the United States, though, like Florida, is up at 300 and 400, and is sometimes up to 700. And so the Philippines is doing better than Florida and Texas, but still really difficult because of the lack of vaccinations. They have deployed several million vaccines, and they approximate about 13% of the country is now vaccinated. But as you can see, it's surpassed the previous surges in terms of daily new infections in the Philippines right now. Particularly hard hit is Cebu. And as you can see, the daily deaths as well initially decreased. Now with Delta, we again are seeing it go up. So why Delta? What is up with Delta in terms of causing all this chaos and really changing my plans for the fall, unfortunately? So we know that the Delta variant is more contagious. It's more contagious than all the other previous strains of COVID. And it causes 2 to 3 times more infections because it's increased transmissibility. So as you can see, typically with the original virus, one person would potentially infect maybe 2 people, maybe 3 people. But now with the Delta variant, it will infect 1, 2, 3, 4, 5 to 6 people. And so that's why more people are getting infected. And so it's spreading 2 or 3 times faster than the original version of the virus. And it's currently dominating all the outbreaks in the United States and is responsible for over 90% of our COVID cases now. And basically what happens is the variant is growing more rapidly inside people's respiratory tracts, and they get to much higher levels. On average, people infected with the Delta variant have about 1,000 times more copies of the virus in their respiratory tracts than those with the original strains of COVID. And so if someone catches Delta, then they're also likely to become infectious sooner. So before, with the original virus, it would take maybe 6 days to get detectable levels, to have symptoms, to then become infectious. But for the Delta variant, it's only taking 4 days. So typically we're seeing is somebody's exposed and in 4 days, they're showing symptoms. And so they start feeling bad and getting tested, and it takes 3 days to get the test back, but they've now already exposed so many people with a very high viral load. And so that's why it spreads so quickly. They're spreading it earlier in the course of infection. And so that's why testing early is important, and then quarantining once you're tested positive is important as well, so that it doesn't continue the chain of transmission. The other issue is that not only it doesn't spread faster than the original, it actually spreads faster than a lot of our other viruses. So faster than the common cold, faster than smallpox, seasonal flu, that it's as transmissible as chickenpox. I know many people, the younger crew doesn't remember chickenpox days, but I think our older nurses and doctors will certainly remember chickenpox being much more contagious. And so as you can see here, this is basically looks at how infectious it is. So how it spreads faster. Measles spreads the fastest, right? And you can see Delta variant is here, and then the ancestral or original strain is here. And so not only does it spread faster and infect more people, but it causes more severe disease. And so more likely to be hospitalized if you're infected with Delta, more likely to require an ICU admission, require oxygen, and more likely, unfortunately, cause death, because it can partially evade the immune system and our antibodies. And so we can't contain it and control it as quickly, and can damage our organ systems much quicker. And we are definitely seeing that in our current surge. So in summary, with the Delta, again, highly contagious, causes more severe disease. And then now, even in our fully vaccinated individuals, it's causing breakthrough infections because it can cause such a high viral load and overcome the effects of the vaccine. And so it ends up having breakthrough infections in our fully vaccinated individuals. And in some cases, and many cases, it can be as transmissible as an unvaccinated case. So you have a fully vaccinated person who's done everything that they were supposed to do. They happen to get infected with Delta, and then they can still potentially transmit to someone else, which again, that's where Dr. Keown's talk with going back to school causes that. It causes a lot of anxiety where our kids are unvaccinated and now I'm fully vaccinated, I may give it to my child. So vaccines, we know, prevent greater than 90% of severe disease, but they may be less effective in preventing infection or transmission. And so that's why this Delta variant has created more breakthroughs, more community transmission and spread despite the vaccination that we've gotten to and have been able to get people to.
Hello. Let me in.
Well, let's see. Let's let someone in. All right. So now just a quick review in terms of our vaccines. Is again, it's been phenomenal up until June when really we weren't seeing any breakthrough infections in our fully vaccinated folks really until Delta came along. And so in terms of the vaccines that were being developed is really they're different platforms, right? You're familiar with most in the United States is who's gotten the most press is Pfizer, Moderna, and J&J. Those are the three ones that are authorized by the FDA here in the United States. The other ones that are approved in many European countries is AstraZeneca. And then as we know in the Philippines, they use a lot of Sinovac as well. And so they use different platforms. The newest platform is really the RNA vaccines, which are really brilliant in terms of how they elicit an immune response. Viral vector platform is a little bit older technology, but also has been very good at being able to elicit an immune response. And so in terms of how they work, and this is just a quick review, this is what, if you're interested in a sort of more detailed review, then you can look back at the webinar that we did back in May, and that's where I went over more of them in detail. And so essentially with the mRNA vaccines, Pfizer and Moderna, what they realized back with SARS, the first SARS outbreaks in 2003, and then with MERS in 2008, was that what we needed to duplicate was this spike protein, because the spike protein is what basically elicits the immune response from the host cell or from us, from the human body. And so if you present the spike protein by itself without the rest of the virus, then you can have an immune response, yet not have the disease infection effects of actually having COVID. And so what they did was they basically figured out the recipe for your cell to create the spike protein, and that recipe is mRNA. And then they basically encapsulated the mRNA into a lipid nanoparticle, and this is what your vaccine is made out of. And what happens is that vaccine then is injected into your muscle cells, and then the muscle cells incorporate this recipe for spike protein, and then it makes spike proteins. And so your body sees this spike protein, you have an immune response, both a B cell and a T cell response. So you activate both arms of your immune system, and your B cells start creating antibodies. Specifically, what we like to look for that are will give us protection is neutralizing antibodies. And then also you have memory B cells, so that over time we know that your antibody levels will wane. But
I want to show you something.
B cells, which eventually will, memory B cells, which will recall the antibodies and eventually produce them again down the line. And same thing with your T cells. Viral vector vaccines, again, this is what your AstraZeneca and Janssen J&J are. They just deliver the recipe for the spike protein in a different way. They use an adenovirus vector to do that, but it ends up eliciting the same type of immune response. And so how effective are they? Again, this is an old slide. This is how they were effective against alpha and the original variant virus. Were again pretty high, and this is against symptomatic disease, where unfortunately Sinovac, which a lot of the world has used, is only at 50%. So they are definitely looking at boosting and having studies where people who've had these lower efficacious vaccines, giving them another vaccine such as Pfizer, mixing and matching to give them more protection. In terms of then the Delta virus, the Delta variant, how is it compare in terms of the vaccine effectiveness? So we know it's reduced. So this is alpha, beta, gamma, and the Delta virus. And so you can see with all of our 3 vaccines here in the United States, it is effective against it, but you get reduced antibody levels. And so this is a very busy slide. But it basically compares all of the different vaccines, and then it looks at in different cohorts and categories of people. So as you can see in terms of COVID death, 100% effective for every single one of these vaccines, which is fantastic. And then it looks at alpha, beta, gamma, delta. And as you can see, you start dropping off in terms of your effectiveness with all of these vaccines. And then Pfizer did its own study. And as you can see, okay, it's looking okay. There's some drop where the triangle is the effectiveness against Delta. The circle is the effectiveness against Alpha. And as you can see, what was really worrisome is what's happening here in Israel, where they're like, this dropped all the way down to 64% in terms of effectiveness against Delta. And so we'll talk about that more later. Then they switched and they looked at immunocompromised people. And they said, immunocompromised people on immunosuppressive therapies and those who are having organ transplants, they actually have lower levels of antibody response. As you can see here with the yellow being much lower in terms of percent with antibody response. And then what they realized was, let's look at COVID hospitalization. Those who are immunocompromised, was only 59% effective versus 91% for COVID hospitalization. So like, that's not good for anybody who's immunocompromised. And then they said, well, what if we give them another dose? Well, let's give them an additional 3rd dose of vaccine. And what they showed was that if you had no detectable antibody, you got your 3rd dose, then that's what then gave you an antibody response. 33 to 50% then developed an antibody response. They also said, hey, let's look at the side effects. And so this slide basically looks at the reactogenicity or the side effects after the 3rd dose. And so that's 3D. And as you can see with 3D, you're still going to get some pain after your injection site. You're still going to get some fatigue. You may get some chills, but pretty much the same as your other doses. So you weren't getting any more side effects having the 3rd dose. So essentially that is what led to the August 13th CDC recommendation that said, hey, we need to recommend a 3rd dose to those who are most at risk for having severe disease. So those would be those who are moderately and severely immunocompromised, that they should get an additional dose. And then this is who they defined as people who are at risk for being immunocompromised. But then what does that leave for all the rest of us, right? In terms of evidence for waning protection over time. And so we know that's natural. That's what's going to happen with a vaccine. When Pfizer looked at it and Moderna looked at it specifically, they saw that the vaccine effectiveness against symptomatic disease was now slipping. It was up at 96% and was down to 84% after 6 months. For Moderna, it was down from 94% to 90%. And so they also started doing trials like, hey, let's give everybody some people a 3rd dose and see what happens. And they actually indeed did see spikes in levels of infection blocking neutralizing antibody. So that's what started us down the road of saying, hey, maybe everybody needs a 3rd dose. And then it was really the data that's coming out of Israel that is now pushing our government to review that and say, ooh, it might be a good idea for us to start giving a third dose, additional dose. And so they looked at Israel's data. Again, they were doing really well. And they were doing really well because they were the first country to really reach fully, more than half of their population being fully vaccinated. So by March, they had over 50% of the country fully vaccinated. Now I think they're up at 78%. And so they saw this huge drop in the number of cases, but look at here. Then it started going up in Israel. And they're like, well, why is it going up? Delta virus? Probably. But they were also thinking, let's look at to see who's getting infected. And so they looked at their data, 514 people hospitalized with severe or critical COVID, and 59% were fully vaccinated. Of those, 87% were 60 or older. The others who were hospitalized, they were unvaccinated, young, healthy, whose conditions deteriorated quickly. But from that, they basically were able to gather data in terms of, maybe it's not just the Delta virus, but it's also that we're having waning immunity that's now causing us to have a decreased effectiveness. And so we know that from their data, vaccine protection against both infection and disease dropped from above 90 to 40% by late June. They did a pre-printed study that showed protection of from COVID-19 during June and July dropped in proportion to the length of time since the person was vaccinated. And then those vaccinated in January, that they again had less effectivity against severe disease and hospitalization. This is what we don't want. We don't want our older folks to be getting sick and getting hospitalized. And then when they gave an additional dose, they noticed that, hey, that they were 2.5 times more protected. So certainly sets up the case for us, where then on August 18th, so just 2 days ago, this is the joint statement that came out, that we know that COVID vaccines, that they are effective in reducing a risk of severe disease, hospitalization, death, even against Delta, that their data is very clear that protection against COVID decreases over time after the initial doses. And then now with the combination of Delta transmissibility and spreading so quickly, that, hey, we might start seeing reduced protection against mild and moderate disease. And is that a forewarning? Is that a forewarning of saying, hey, now we're not only going to see mild and moderate disease, but will it get to the point where our immunity wanes and Delta is there, where now we also have diminished protection against severe disease, hospitalization, and death? And so essentially saying, hey, let's do a booster shot, that we may need this to maximize our vaccine-induced protection and prolong its durability. And so the CDC Advisory Committee on Immunization Practices is going to meet, I think, next week on Tuesday to review the evidence and give recommendations. And typically the FDA is the next in line to then review all the evidence. And that's what will decide essentially where we'll be in this country in terms of recommendations for the third dose. The government, however, President Biden and our Health and Human Services, they came out and they said, well, we're prepared. If you give the recommendation for a third dose, we're prepared to start boosting all Americans starting the week of September 20th, 8 months after an individual's second dose. So that's what I have for now for just the sort of the quick review and also addressing lots of questions that had come through previously. And so what I'll do now is I'll hand it over to Dr. Keown, who actually has the harder job of trying to advise about return to school and what do we do with our kids who are unvaccinated. All right. Oh, I think I have to stop sharing, right?
Yes.
Okay. I have to enlarge my thing right there. Hello, everyone. And yes, I'm in clinic right now and it's really crazy. um, because everyone is trying to get things done before school starts, particularly here in DC, which starts, I think, the end of August, which is a week from now. And if you probably know from what's been going on, people have not actually been going to the doctor for this length of time, particular for like preventive medicine, for coming in for their well child visits or to get their shots. So just like this morning, we had like 4 kids who needed like 5 shots between each one of them, because that's what they needed. But that's basically the challenge we have right now, is just catching up with all the regular care that all the kids need to be able to start school. And a lot of schools have school systems have really been stricter, I think, more than any time before, about really imposing their no shots, no school policy. And that definitely is understandable, particularly since I'm talking to all of you who are in the healthcare field, and believing that schools, our immunization vaccinations are definitely very, very much a big part of keeping everyone healthy. So anyway, let me thank you everyone for who organized this, the Philippine Nurses Association, definitely Kathy, Dr. Ferrer, and also Ms. Graham, who's also joining me in this talk about COVID and updating you in what's happening. And I know the new challenge is going back to school. And why are we doing this? Why is the schools, why are the school systems, why is the government, why is the federal government really trying to push kids to school? And this is from the American Academy of Pediatrics Council on School Health. I think the most, I mean, we do know that COVID is a health problem. It's a medical problem, but it has definitely taken an impact. It's given an impact and considerable impact on kids. And it's not just their education. It has definitely impacted their mental, emotional, and physical health. And those are very much, and as pediatricians, those are very important parts of who our kids are, and we want to make sure that they're healthy all around. So and that is one of the biggest reasons. And we do know, and then I'll go through a little bit of a discussion, that if we just practice good public health policies and strategies, we would be able to get kids back to school so that we can take care of the other things the kids are need to be able to grow, to be healthy people or healthy individuals. So this is, and then a lot of, in education, a lot of people are already thinking about 2020 or in 2019 as the lost year in terms of education. And this is the RAND Corporation. If you know the RAND Corporation, these are big numbers of, they look at big data. And in a lot of schools, even particularly in high poverty schools, particularly here in DC, probably areas in California, in the South, everywhere, there are high poverty areas. 1 in 3 teachers report that their students are less prepared now for the grade level work than they were before. And even in areas as, I would say, as affluent as Fairfax County, and one of the biggest school systems in the country, they're seeing a lot more class failures. And even in small areas as Greenville, South Carolina, they're seeing the same thing. And then we're nationwide, they've already seen a drop in math achievement. So this is one of, in education-wise, virtual learning has not really worked for most of the kids. One of the biggest considerations to think about as part of the reason, and just part, is that there is still a very big digital equity gap. There's a lot of kids that are going to school with bad Wi-Fi. Wi-Fi doesn't work. It's coming in and out, or and we all have experienced this as we all went into the virtual world. But we're just think about when you're trying to study arithmetic, 1 + 1, or even as much as geography or civics, if you don't have good Wi-Fi and you're a 13-year-old student, and how that really affects your education or your interest in being able to learn virtually. And unfortunately, and the big thing that we just have to think about is that unfortunately, preparedness has been heavily tied to income, and that's the biggest gap that we that has been picked up from last year. So there's a big equity problem that we need to address. So according to the American Academy of Pediatrics, which myself and Dr. Ferrer are part of, is that we can open the schools safely so that we are able to catch up with the other educational stuff and the mental health stuff and all the other things. And the other part that the American Academy of Pediatrics is saying is that the schools opening schools have not significantly increased community transmission. And I think that's the most important part of this talk, is that if we did public health strategies, including masking, we can definitely control the spread of COVID. And the key takeaways, and I know all of you are aware of this, but it's just a good thing to be able to reinforce this as your patients are asking you, and as your family members are asking you, that these are the main things that we can do to make school opening safe. One is vaccination, and that's and Dr. Ferrer addressed that. The other thing is universal indoor masking. Unfortunately, we thought that we would not have to do this, as Dr. Ferrer mentioned, around June, but unfortunately with the Delta variant as a problem this fall, we're back to universal indoor masking. And it's very unfortunate also that there are certain school systems, and not only school systems, I think states, that are banning indoor masking. This is a big problem. So as you see, and as you pay attention to the news, you could see that the school systems are really trying to address this by being creative and making their mandates on masking. So this is the most important part of how we are going to be able to open schools safely. Again, back to just physical distance, at least 3 feet is the recommendation now from the CDC. And again, the other big part of the way to address it is really community-wide, which includes screening, which is some schools are going to be doing in their schools. And I think over the past year, while the students were in virtual learning, a lot of schools, a lot of money, federal, has gone into school systems to improve ventilation. Also, the ability to do more frequent hand washing, ability of having anti-germ gels available and more accessible to the children and all the staff is going to be important, and respiratory etiquette, and which is really another part. If you do have a cold, if you do have a cough, that they need to be sent home. Contact tracing will be part of that, including quarantine and isolation. And of course, all the other things that include cleaning and disinfecting the schools. So we did mention about staying home. If there was any illness, I think I don't have a really good, there's what they call a Swiss cheese approach, where all the holes are, where the holes of the cheese are in various places, and each of the holes address the different ways that infection is spread, so that we are using, again, multiple prevention strategies to be able to prevent the spread. And then there's community ways to transmit, to definitely monitor the transmission of COVID in the community. So I think this just goes back to another thought, is that, and this is actually the biggest challenge that we have right now, is a lot of parents wanting to get, we've heard about why it's important to go back to school. And that's why there's a big push, even from our academy, to get children back to schools, including kids with disabilities. And these are disabilities that and there's a list of different conditions and diseases, particular chronic illnesses that can exempt you from going back to in-person schooling. But for the most part of kids with disabilities, you have to balance their access to other services, particularly occupational, physical, and speech language therapy, which has not been successful on virtual learning and can only be done on in-person learning. So you really need to be thinking about that. I think that's the end of my talk. I do want to have you visit the CDC. There's a list of conditions where you can get exempt from going back to school, but definitely for the most part, most kids should be going back to school. Thank you very much. And then we will, during the question and answer part, we can talk to more in detail if you have any other concerns or questions. And I will try to stop sharing. Did I just not do that?
Yes.
I already did. Okay. So I'd like to give Kathy Graham the floor. She's going to talk more on how the more practical ways of talking to our community about getting the public health stuff done. So thank you, Kathy.
Hello, everyone, and good morning. My name is Catherine Graham, also known as Kat to many. I would like to thank each and every one of you for registering for today's COVID webinar. My hope is that by the end of this talk that Dr. Ferrer, Dr. Keon, and myself have presented, especially for those that are still hesitant with the vaccine, that you be provided with enough facts to change your mind and to also encourage others to seek vaccination. A newer strain of COVID-19, the Delta variant, which originated in India, is causing concern as cases are rising. According to the CDC COVID data tracker, as of today, there have been 624,213 deaths in the US alone. Imagine the death toll in other countries. Folks, cases are rising, especially in unvaccinated states, as Dr. Ferrer had mentioned earlier. Healthcare workers are exhausted. We're burnt out. Hospitals are filling up again at max capacity. With that being said, let us tackle the common COVID myths and the truth or facts associated with each one. Next slide. Myth number one. The vaccine is not safe because it was rapidly developed and tested. The fact is, when we are in the middle of a pandemic and literally thousands of people are dying on a daily basis, of course it makes sense to expedite the process of making a vaccine available. Being granted emergency use authorization doesn't mean that research or monitoring stops. There are still many layers of safety involved, and no corners were cut in the clinical trials. Next slide, please. And both the Pfizer and the Moderna vaccines were created with messenger RNA technology that has been in development for years and even decades. So companies could start the vaccine development process early in the pandemic. Next slide. Myth number two, the vaccine can alter my DNA. The fact is, COVID-19 vaccines do not change or interact with your DNA in any way. The mRNA never enters the nucleus where the DNA is stored. mRNA only tells your body cells to make spike proteins and fools your body into thinking it sees COVID. So your immune system creates antibodies to the spike protein, so your body is ready to fight off the real virus. Next slide. Next slide. And myth number three, If I've already have COVID, I don't need a vaccine. Next slide. The fact is, vaccines may offer better protection than natural infection. Early evidence suggests that natural immunity from COVID-19 may not last very long, and not enough information is available to say how long after infection someone is protected. Studies are also showing that the Delta variant is affecting unvaccinated people more. Myth number 4, young, healthy adults don't need to be vaccinated. The fact is, though people over 65 are much more likely to get severely ill from a coronavirus infection, young people in their 20s, 30s, 40s, and even 50s are still getting hospitalized. Unvaccinated people can easily get infected and spread it to someone, especially people that are more vulnerable or with compromised immune systems. Young people can experience a range of symptoms that can last weeks or months after infection. According to CDC, symptoms include shortness of breath, brain fog, chronic fatigue, and chest pain. Young people still die of COVID. I have a nurse friend who had admitted a young 28-year-old man in an ICU because he was actually infected by his wife, who tested positive. And unfortunately, both are unvaccinated. Myth number 5, getting the COVID-19 vaccine means I can stop wearing my mask and taking coronavirus precautions. Fact is, vaccines do not stop the coronavirus from entering the body. You are fully vaccinated after 2 weeks. And like all vaccines, efficacy is not 100%. For those who are vaccinated, the risk is still lower and symptoms are milder compared to those who are not vaccinated. You're less likely to require hospitalization and intubation, which brings me to my second point. Folks, nothing is 100%. For example, birth control. There's still that small percentage that you can get pregnant, correct? You can still have a heart attack despite exercising regularly and eating a healthy diet. No medication is 100% effective. So does that mean you're not going to take it? Next slide. Myth number 6, the
Hey, Doc,
COVID-19
we're
vaccine
going to go pee first.
can affect women's fertility. While studies are going, there's still no evidence to show that vaccine leads to reduced fertility. There's currently no evidence that COVID vaccines cause any problems with pregnancy, including the development of the placenta. We at Children's Hospital have vaccinated a number of pregnant employees, and they told us that their OBGYN have all recommended that they get vaccinated, because when pregnant women get infected with COVID, they are actually at higher risks for complications such as pneumonia, hypertension, maternal death, preterm and stillbirths. Myth number 7, the side effects of the vaccine are dangerous. Side effects are short-term, not serious or dangerous. Common side effects include pain, an injection site, body aches, fevers, chills, and fatigue. Keep in mind that this is all normal. It means your body's immune response is working. You should be worried about the serious side effects of getting COVID, which means the long list of respiratory issues that could lead to intubation and possibly death. Myth number 8, vaccines contain the coronavirus so they can give you COVID. Nothing can be further from the truth. There is absolutely no COVID virus in this vaccine. The vaccine teaches your body to respond to the COVID virus by mounting an immune response. And you may experience symptoms after getting the vaccine, which is a sign your immune system is working. And last but not least, myth number 9, the vaccines don't work on new strains of the virus, especially the Delta variant. Current vaccines have shown effectiveness in protecting against or at least minimizing the damage from a Delta variant infection. And being fully vaccinated can protect you from the Delta variant. However, as Dr. Ferrer had mentioned, breakthrough infections, although rare, can sometimes still occur. And symptoms of those vaccinated from infections are less severe. Most have no symptoms or have very mild symptoms, and it rarely results in hospitalization or death. As an occupational health nurse at our hospital, part of my duties involve giving the Pfizer vaccine to our employees. And I wanted to share an experience I had with an African American manager who was greatly impacted by her experience with the whole COVID vaccine process. She was actually there just supporting one of her employees who came to my line for vaccination. I didn't realize that she had already received the first dose and was not planning on getting the second dose after all the side effects that she experienced initially. She told me that she became very ill. She stated that it was the way that I delivered the information to her about COVID and the way she saw me interact with others with my bubbly, calming, and reassuring personality that really changed her mind. Not to mention, she was also scared of needles. I told her, get in my line and you won't feel a thing. Sometimes with people, you have to listen to what their fears are and try to address them. With some, I asked them, what's important to you? Is family important? Being able to travel again? Eat out at your restaurants? Go to concerts? Now, in some places, I know they are requiring proof of vaccination before they even let you dine in. It felt good to know that in a short amount of interaction with her, that I was able to create that much of an impact. And today I hope to be able to do the same. I too was scared in the beginning, but how can I, as a healthcare worker, provide vaccines, talk about its benefits, and not be vaccinated myself? We all have to do our due diligence and just do your research, do your own research. And, I thought, we're nurses. We rank as one of the top most trusted professionals. So why not get the vaccine and talk about my own personal experience with everyone? So that one day, while observing employees for 15 minutes after their vaccination, the manager of occupational health asked me, hey, Kat, we have an extra dose. Well, you don't want it to go to waste. Do you want it? Of course, I said yes. And the rest was history. With that being said, I just wanted to share a few more facts before I end my part of this presentation. And more facts is that the more people who are unvaccinated and infected, the more chances there are for mutations to occur. And according to a study, 97% of people now entering the hospital with COVID-19 are not vaccinated, according to the director of the US Centers for Disease Control and Prevention. Now, the good news is children now 12 years and 12 years and older are now eligible for the vaccines. So if you know anyone that is still not vaccinated, here are ways in which you can find a COVID vaccine near you. You can either go to vaccines.gov, or you can text your zip code to 438829, or simply call 1-800-232-0233. Thank you.
Thank you so much, Kat and Dr. Kathy Ferrer, Dr. Natalie Keon, for the excellent presentation and also for the important information. I hope most of you have gained some of this knowledge to help you out. And hopefully we can have our families, our friends, our colleagues to get vaccinated. And now we are open for questions and answers. We actually had gathered a lot of the questions from all those who have registered. And Lourdes, would you like to ask the first question?
Oh, sorry. Hi, everyone. Oops, sorry. There was actually a question in the Facebook live streaming. Someone asked if they had received Sinovac, will they be able to access Pfizer or Moderna for their booster? And I think that might be Dr. Kathy Ferrer or Dr. Keon's question.
Sure. So they definitely have done lots of, or doing more ongoing studies in terms of mixing and matching vaccines. They're calling it heterologous vaccine administration. The ones they've tested the most are AstraZeneca, and then doing a Pfizer vaccine afterwards, or flipping it. And so that was a big study done in the UK, and actually showed that it was more effective if you did AstraZeneca and then you did Pfizer, because you're using two different platforms for the vaccine. For Sinovac, definitely people and countries are authorizing a second vaccine to be Pfizer after the Sinovac. Actually, in June, the Philippines is conducting a big study where they're doing Sinovac and then seeing the other vaccines that have been approved in the Philippines, and seeing what the efficacy is after you do that combination. So it's definitely coming. The WHO hasn't put out formal recommendations yet, but countries like, I believe, Germany, Canada, Thailand, all of them are doing things where AstraZeneca is the first one, and then doing Pfizer after that. So it's coming, and we know that with vaccine shortages, that it's going to be very important to have the data in order to have the evidence to basically look at the efficacy of it. And it's showing also that it is safe to do to mix and match the different brands of vaccine and platforms of vaccine. So more to come on that for sure.
Thank you, Dr. Ferrer.
I have another question from Facebook. Is monoclonal antibody infusion a choice of treatment for non-vaccinated?
Yes, definitely. Monoclonal antibody, basically when we are screening and triaging our employees, and when they turn positive and they're unvaccinated, then we also tell them they need to really speak with their primary care physicians to look to see if they have any comorbidities or higher risk for severe disease. And if they do, like hypertension, heart disease, diabetes, obesity, then they are eligible to get monoclonal antibodies. We've had a couple of our employees get monoclonal antibodies, and it tends to shorten the course of disease and help them feel better more quickly and decrease the chances that they're hospitalized. So certainly monoclonal antibodies is something, if you get infected or someone you know gets infected, should ask your doctor to see if you would be eligible, if it would be beneficial for you. It's better to get monoclonal antibodies earlier in your course. And so certainly would be in touch as soon as we get that positive result. You can also give it in unvaccinated and fully vaccinated people. So.
Go ahead,
sorry, Ida.
Go ahead, Lourdes.
I have one from Josh Agawin on the chat site. The question was, is the current protocol regarding co-administration of COVID vaccines with any other vaccines such as rabies, pneumococcal, and flu vaccine? Can you share some current protocol guidelines on that? Combinations of vaccinations, especially with the flu vaccine season, a flu season coming on board.
So as I mentioned, we are actually trying to catch up a lot of kids in terms of the vaccines from 12 years old and above. And we've been administering a number of vaccines together, including the COVID vaccine. So there's theoretically, there's nothing that would keep you from not getting the COVID vaccine with the other vaccine. So definitely as the flu vaccine comes out, which is I think available already and will be more available by September, if that one visit to the doctor. If you can get the flu vaccine and the COVID vaccine together, go ahead and do it.
Thank you, Dr. Keon.
I got one from Erlinda Gonzalez. I heard that if the second dose of vaccine would have been given 3 months after the first dose, it would be more effective, last longer. Of course, I have heard a lot about a booster. What is your opinion on that?
Yes, I also have seen that data where if you actually lengthen the time to between your first and second vaccine, that you actually had more durable immunity. I'm not as familiar in terms of the nuances of that data, but in terms of the booster, it's certainly something that I will be getting when it's available and something I would recommend to my friends and family. The question really is timing in terms of when you want to get it. As I had mentioned with that Israeli data, is right now our vaccination is holding up against, and we're having breakthrough infections with potentially mild and moderate disease. But once we start it ticking up like it did in Israel, where you're now getting hospitalizations, that's where I say, please boost me, because I do not want to risk hospitalizations. I also don't want to risk long COVID. That's the other parameter that should go into your calculation. So I think, once it's available, I would definitely, especially if I want to travel, then I would definitely, and if I want to go back to the Philippines, for sure, I'm going to get myself the booster before, so I can, again, assure myself that I've increased my immunity again.
Lourdes?
Have a question from Prima Colburn. If after quarantining for 10 days and still has symptoms, are you still considered contagious?
If you had, are they quarantining because they were exposed to someone with COVID? If they were quarantining because you were exposed to someone with COVID, then after 10 days, you are out of that window period of potentially developing infection. But if you develop symptoms, that's another story. Then if you develop symptoms, then you should isolate and you should get yourself tested. Now, if you had COVID and then you're isolating for 10 days after your COVID infection, typically, again, if you're COVID positive, you're considered infectious 2 days before your infection and 2 days before your symptom onset and 10 days after your symptom onset. If you're still having symptoms, then I would remain isolated and then definitely talk to your physician in terms of when you can come out of isolation. Our current guidelines for taking someone out of isolation is that 10 days have passed since their symptom onset, that they have not had a fever in over 24 hours without the use of Tylenol or ibuprofen, and that their symptoms have generally improved. So you may still have lingering symptoms. Oftentimes you still might have a cough, you might have a little bit of some congestion, oftentimes some fatigue, but you're not considered infectious at that time. But I would definitely talk to your physician, and you may need a longer amount of time out. They have shown that Delta can shed for a longer amount of time. If you're fully vaccinated though, then that time period is shortened. So it really depends on a couple of different factors.
Okay. I have a question from Yolanda Maron. In the admitted patients, does your hospital use remdesivir, ivermectin, and or CCP?
CCP, what is that? I'm not sure what that's referring to.
Yolanda?
We do use remdesivir at children's. Of course, I'm not taking care of adults, and we do not use ivermectin. And I'm assuming is that convalescent plasma? We have used convalescent plasma in the past.
Yes, CCP is the convalescent plasma, that's what I meant.
Okay. Thank you.
Thank you.
I have one also from Daryl M. Does someone died of getting the vaccine?
No one has died as a result of the vaccine. Obviously, lots of people have died as a result of COVID. In terms of the vaccine, of looking at the data, there has been no correlation between the vaccine and I'm talking about Pfizer and Moderna and dying. That again, in terms of serious adverse events for the vaccine, that they are minimal compared to obviously having COVID. And so again, that is actually a great question, because oftentimes that is people are very hesitant to get the vaccine because they think that it will cause more side effects or long-term side effects potentially. But what they have shown is that it doesn't. Obviously, we know COVID does, so that's a no-brainer. But in terms of vaccine, as far as long-term side effects, no long-term side effects with Pfizer and Moderna, and in particular vaccines in general. So the basic science of vaccines is that they deliver their payload and you're one and done. And so, and then it disappears from your body, right? That's actually why Moderna and Pfizer, you are required to store it at -80 degrees, because it's so fragile that it basically disintegrates if it's in room temperature for any amount of time, for it over like 6 or 7 hours. And so that's why they don't cause long-term side effects. You see side effects usually within 6 to 8 weeks. Again, typically it'll be 2 to 3 days after vaccination. I'm sure there are some deaths, like maybe 7,000 deaths there may have been recorded in terms of it being directly correlated or caused by the vaccine. We don't think so. There obviously you can die of something else and it's correlated potentially, but not caused by. But if you think about the billions of vaccines, and in the United States, I think it's 330 million vaccines that we've given. That certainly that is a very rare event.
Lourdes?
I just wanted to make sure that I highlight all the compliments and kudos that the presentation and presenters, the speakers, are very informative. The research data that have been shared, statistics, they are particularly very enthusiastic about hearing about the Delta variant based on evidence-based and statistics that that the speakers had all shared. One of the comments from President Mary Joy Garcia said that you presented this clinical information, Dr. Ferrer, the most meaningful process, sharing statistics that support the importance of vaccine. So excellent presentation all around, and kudos to everyone. I don't have any question from the chat, unless perhaps Ida, if you have more time, we can open it up for
Okay.
like live questionings. and
Sure.
chats.
Yes, I have a question from Anne Marie. And on mixed vaccines, if a person had the 2 doses of Sinovac and a Moderna or Pfizer vaccine is available, will it hurt to get that 3rd dose regardless of when the Sinovac was last given?
I don't think we necessarily have data on that yet that I've seen published. I know that anecdotally, people have been doing it, and scientifically, and looking at the science behind all the vaccines, I don't think it will hurt to get the 3rd dose of Pfizer on top of your 2 Sinovacs, or Moderna on top of your 2 Sinovacs. I suspect that is where I believe many countries have gone already, actually, where again, because the Pfizer and Moderna have had so much more efficacy, and also particularly with the Delta variant, that is where several countries are heading in that direction.
Yeah. I have also from Cecilia Garabrand. What do you suggest a person who had an allergic reaction to the COVID-19 do?
Assuming they
To the
mean to the
vaccine, yeah,
COVID-19 vaccine. So the first thing I would do is I would see an allergist, because they need to verify that it is a true allergy first. And I know that our allergy and immunology team, they have actually now specific clinics where they're addressing this. As a true allergic reaction to the mRNA vaccines is very rare. It's typically if you've had history of severe reaction to one of the components of now.
Relax.
Is it a
Roughly
yeah, probably,
Yes.
yeah.
Yeah, so it's
Polyethylene
Miralax.
glycol. Thank you, Natalie. Polyethylene glycol.
Yeah, yeah.
Natalie, how do you advise your patients?
So far, yes, it's the same thing as you, because there's a lot of hesitancy, and I don't want to be able to, I want to acknowledge that hesitancy. And if there's true allergy, there's a history of true allergies, send them to the allergist to verify it. But so far, of the many doses that we've already administered here in the clinic, we have had no allergic reaction to the COVID vaccine. And I'm sure that also has not happened even in the hospital, where you've also administered thousands of doses as well.
Yeah, so we've administered well over 12,000 doses at our own hospital. Kat has probably given about 50% of them. And we have had no true anaphylactic reactions to the vaccine.
Yeah, there's a question from Romeo de Vera. Is there such thing as over-vaccinated?
Good question. I think Kat will be like, "Are you here again?" She'll catch you though. We don't think so. Again, one of the questions actually that I'm thinking about that kept coming through was, will we need a vaccine every year, right? Like we need the flu vaccine every year. I don't think so. I think it's going to be, how hepatitis B, we have 3 vaccines and you're pretty much done, but you might still have some people who don't react and may need another series. I think it'll be closer to that than it is to the flu, where we need it every single year, just because the flu mutates much faster and much more than the COVID virus. And so because it's doesn't mutate quite as much, that hopefully we can get to 3 and then you reach an immunity level that's plateaued, and getting more vaccines won't be helpful. So again, obviously more data to come on that. And so we'll see. I'm hoping it isn't both.
Yeah,
Very much hoping that it's not a yearly thing.
yeah.
So
And yeah, from Cecilia, she said that her sister has an allergic reaction from Sinovac. Is there any other way that, what she can have the other ones
yeah, if she had a
from another company?
reaction, then I would say she should definitely seek one from another company. I know that there's a lot of brand issues in the Philippines right now, so they actually have gone to a point where they're not telling you which one you're getting, which can be problematic, obviously, down the line. But because everybody is like flocking to the Pfizer vaccination sites, and they just don't have as much that, and then people are saying, well, I'm just not going to get vaccinated, I'm going to wait for Pfizer. That also isn't a great great strategy. Natalie, Dr. Keown?
I would say the same, and I had to be honest, I'm not as well informed about how the other vaccines are manufactured. Examples of this are, for example, where like measles vaccine, they do have, there's some component of egg in that. So people with, or in flu vaccine, there's some component of egg in it, that there is some concern about getting the measles or the flu vaccine if you have an egg allergy. But even with that, the allergists pretty much just say, even just monitoring and giving still the vaccines are very effective, and just monitoring them after and administering anti-allergy medicine after is better than not taking the vaccine. So it's really something that, so I would need to know more about Sinovac. Unfortunately, I don't. Yeah.
Yeah. How about, there's one from Joss that says the circulating, about the circulating from media. there are circulating media posts regarding the strict ordinances on being inoculated with specific vaccines, most excluding Sinovac and Sputnik Gamaleya 5 prior to traveling to certain countries. What would be the reason for this? Is it sort of a political factor or more from the evidence-based studies and efficacy of this vaccine?
Yeah, I think it probably has to do with the efficacy. I know that Sinovac oftentimes is not recognized, even though it is recognized, I believe, by the WHO, but many countries are not recognizing it because of its efficacy of being at 50%. For the Sputnik one, the Gamaleya, its data has shown that it is quite effective. So that might be a political reason. So I'm not sure about why they would be not allowing the Gamaleya one. But I think it's because Gamaleya, I don't think has been approved by the WHO as of yet.
Yeah. Okay. I know it's almost time to close. However, I have one more question. My son was in the hospital back and forth. He has diabetes, heart disease, kidney issues. Is he safe to get vaccine?
Yes, definitely. In terms of, that's even a more reason to be vaccinated because he has a lot of underlying issues and comorbidities. I see Dr. Keown shaking her head. Please chime in terms of how you counsel your parents with kids who have underlying comorbidities.
Yeah.
Yes, unfortunately, there's a lot of, I've been getting a lot of requests from a lot of parents to write letters to exempt patients from going to school because of underlying comorbidities. But at the same time, these patients are the ones, some of them won't get the vaccine, then that's not fair in terms of, there's definitely very good data that definitely says that the vaccine will protect them, and them not going to school is actually, it's detrimental to their overall health. I think that's the most important thing that I wanted to bring about in my talk, is that we have to not just think about the physical health, because definitely in the past year, one of the biggest thing I saw is the rise in other problems, particularly behavioral developmental for younger kids, and also anxiety and depression is really on the rise with all our kids. So do think about that before you make that decision of keeping your children at home and not getting vaccinated, because those are the things that they will be missing out. And also the social development is a whole other arena that the kids are not are having a big trouble right now. So think about that.
I hope
That's how I
have
address
a
it.
question.
Go ahead.
Thank you.
This is Violeta. I have a question on one of my friends. She's going through chemotherapy and she's immunocompromised, and she asked me if is it okay for her to get the booster. And I told her to talk to her oncologist, but the oncologist said yes, but he's not convinced. Is that okay? Is it safe? What's the short-term and long-term adverse effect of that if she does take it?
Yes, so again, from looking at our data, she's actually the prime candidate to get the additional dose, because we know that, again, if she's on immunosuppressive therapy, that her response to the primary vaccine series may have been inadequate. And that third dose will give her enough to then prevent severe disease and hospitalization because of COVID if she ends up being exposed to it. And so I think you said she's getting active cancer treatment, is that right?
Yes.
And so she's actually in the category that on August 13th, the CDC said, yes, we recommend that you get an additional dose.
So what is the long-term or short-term side effect that she should expect? Because she's so worried that she may
Great question.
get sick before the chemotherapy due. So.
Yeah, I think that's
And what is the timing?
Yeah, I think she definitely needs to talk about that in terms of timing with her a doctor, as opposed to when she's going to get the next round of chemo. Ideally, you'll get it before your next round of chemo so that you can react the best to it. But again, she should discuss that with her primary oncologist. In terms of side effects, you can expect similar side effects to when she had either the second dose or the first dose, that they seem to be very similar and not to be any more side effects or any less, about the same as previous doses.
Okay, thank you, Dr.
Well,
Ferrer.
thank you very
Doc-
much.
yeah.
Mhm. Thank
Thank
you.
you, Dr. Ferrer, Dr. Kian, and Kat Graham. And now, I hope we answered most of your questions. If not, we will be able, you can, we will share Dr. Ferrer's, Dr. Kian's, and Kat Graham's email. And if you can, for the contact information. And now, Carol.
Hello, I'm here to introduce our closing remarks speaker. Dr. Mary Joy Garcia Dia is the Program Director, Nursing Informatics, Information Technology Department at New York Presbyterian and board member of the Health Information Management System Society, New York State Chapter. Mary Joy received her Bachelor of Science from the University of St. LaSalle College of Nursing, graduating cum laude. She has a master's degree in nursing informatics from New York University Rory Mayer College of Nursing, receiving the Distinguished Graduate Award. She completed her doctorate in nursing practice with leadership track from the Case Western Reserve University Francis Payne Bolton School of Nursing, and was the recipient of the Director's Award. She published a book, Project Management in Nursing Informatics, released in January 2019, and contributed to book chapters on nursing informatics, curriculum development, nursing practice implications, and human-centered design thinking and clinical workflow in nursing informatics. She is active in the community as the immediate chair of Kalusugan Health Coalition and National Advisory Committee member for research on Asian American, Native Hawaiian, and Pacific Islander health. Her community engagement and scholarly work led to her fellowship in the New York Academy of Medicine and the American Academy of Nursing. As the president-elect of the Philippine Nurses Association of America, Mary Joy launched the Heal Our Nurses campaign as part of the COVID-19 Task Force initiatives on April 3, 2020. She was inducted as the 21st president of PNAA on July 4, 2020. Dr. Garcia Dia joined the Calderon Senior Nurse Executive Fellowship Program in March 2021, a program created by Marian Shaughnessy Leadership Academy in partnership with the American Nurses Association, the American Organization of Nursing Leadership, and the Healthcare Financial Management Association to enhance and expand the development of senior nurse executive leaders. Let us welcome Dr. Mary Joy Garcia Dia.
Thank you so much, Carol Robles. I did not expect that you will introduce me in such a long period of time where I am only supposed to be providing 3 minutes of my time. But I hope that everyone really take this debunking COVID-19 vaccine myth seriously. It affected many of our Filipino American communities. We continue to struggle, and a lot of our chapters, particularly in Florida, Texas, California, where the surge has been continuously going up, are exhausted. In fact, even one of our Filipino nurse here in New York State, because of her public service in trying to provide masks in the subway, was assaulted. So this is not just a personal level from our own perspective, but it's really a public health concern, knowing that COVID-19 have divided many of our communities. And we as Filipino American nurses are strong, and this particular session shows our Bayanihan spirit in working together with different organizations interprofessionally. And I hope that many of us have those takeaways, because I myself am not a subject matter expert, but I appreciated the data, the facts, and the practical recommendations that we have heard. And we have a responsibility to share that with our friends and family. So thank you so much for this opportunity. We appreciate Dr. Kathy Ferrer, Dr. Natalie Keon, and of course, Dr. Catherine Graham, who I know that if she was my nurse, I would readily take the third vaccine boost. So thank you so much, and also PNA Metro DC for leading the way.
Thank you, Dr. Dia. No, I guess we can all unmute.
Can we
We're
take
still-
screenshots of the attendees?
Okay.
It doesn't show.
Okay, we'll give time for the others to turn on their camera. Okay, we'll take several shots, okay? 1, 2, 3. 1, 2, 3. Okay. One more. 1, 2, 3. Another one. Okay, and last, your best smile. 1, 2, 3. Okay, we're good.
Thank you.
Thank you, everyone. Thank you.
Thank
Have a
you
nice
so
weekend.
much.
Thank you for
Thank you,
joining us.
everybody.
Thank
Thank
you.
you. Great presentation. Thank
Hi,
you.
Linda.
Hey, Lourdes.
Thank you. Great job.
Yes,
Excellent job, guys.
Thank you.
Hi,
Our
Lourdes.
speakers.
Thank you all.
Hi, Ate Ida.
Hi.
Thank
And
you,
if- yeah.
Dr. Ferrer,
Hello,
for your
Marisa.
advice.
Hello. Excellent job.
Great job, Ides.
Thank you all for joining us.
Thank
And
you.
if you need more information, I shared their email, or you can contact me and I can refer you to them. So
Can we, this is Pearlie from San Diego. Can we share the recorded webinar to our own chapter?
Dr. Ferrer?
Yes,
Dr.
absolutely.
Yeah,
Okay.
yes. Actually, Pearlie, we are live stream on Facebook. So if they just go to PNAA Facebook page, they can watch the whole. Yeah.
Yeah, because I no offense to Dr. Kathy and Natalie, but the approach of Catherine is so beneficial for us as trusted messenger. And I can relate to that. All the other informations I think are great, just statistics, but how can we prove ourselves as trusted messenger is the basic carry on short conversation.
Yes.
Open them up. And if we can get 1 or 2, that would be great success.
Yay.
Yes, and I think sharing our own experiences too is the most important thing, because even with my families, most of my families, there's one that's still not vaccinated, and no matter how much I try to convince her, even the scientific, the evidence-based, data and all the stuff, it's in her mind that, she said she would rather die from COVID than take the vaccine. So how can you convince somebody like that? No, right?
Yeah. Pearlie, you are absolutely right. CAT is the backbone of our program, and really all the data and statistics is not what's going to convince these last 20% to do it. It's exactly why CAT's presentation was so key, because it's that personal story, that that personal touch. I mean, everyone who is nervous, I just send them to Kat, and she just body level. She charges people.
I charge $10 per vaccine.
But it makes a huge difference. And that's where I think nursing has been really key with getting that personal touch. You can have as much data, as many charts, as many slides as you want, but it comes to that personal touch. So.
And sharing the experience. I have a 97-year-old grandmother. 4 vaccination sites that we did, she didn't want to. On her 97th birthday, a lot of her grandchildren called, "Grandma, we don't want to come on your birthday. We don't want to give you the vaccine because you're not vaccinated. We're protecting you." Next time she saw me, "Pearly, when can you vaccinate me?"
Withholding
We vaccinated her. She
grandchildren.
didn't have to get off the car. We made a big deal of how important this is, and now she's talking to others about the vaccine. 97-year-old, very cognitive. Short story to share.
Withholding grandchildren, that's another stress.
Yeah.
I want to personally thank Dr. Ferrer for making 2 grandchildren very happy this weekend to see each other.
Good.
Thank you much.
Of course.
Good. If any of you would like to share your experience, and also the other thing too is for us, even, I'm retired, but and most of our nurses in PNA Metro DC are retired too. They volunteer to vaccinate on the different community organizations. And I think that's the other thing that we can do. If your Phil group needs, like if they set up like a vaccination, time or schedule, or we can volunteer as vaccinators, and that's what PNA Metro DC has been doing, with partnering with the other community organizations. And I think I saw most of you. Huh?
I will volunteer.
Come to DC.
Yes, in DC.
I think
Another
Yeah,
experience in San Diego, we were holding placards like the pizza guys, the pizza boys, and we were turning around. There were 18 registered on site. At the end of the day, we vaccinated 48. Those cars that just turn in from all this advertising. It's affected anything.
Thank you. Thank you for sharing.
Another thing that I think people don't really share is their own personal experience. I know we only did like a session, I think 1 or 2, some in New York. But for example, for myself personally, I have hypertension. I have asthma since I was 5 years old. I have sarcoidosis. And all of that makes me really want to get the vaccine. But also I was fearful, what will I experience after taking the vaccine? So I think in terms of sharing those personal health concerns, and we brave ourselves to take the vaccine, that would also probably resonate with other people.
Thank you, Dr. Dia. That was really
Thank you, Dr.
great.
Dia.
Yeah. Anybody else who wants to share their experiences?
New York next time.
Yeah.
Yes. 43rd National Convention in New York, July 6 to 10.
We'll be there.
Everyone is invited, including Kathy, Dr. Kathy Ferrer.
Dr. Keon and Dr.
Yes, and also Kat Graham.
I'm a member now. I'm a member.
Yeah.
Oh, yay.
Finally.
Yay! Yes, and just a little plug, you're also invited for our 50th founding anniversary, November 20th at the MGM National Harbor. Please save the date.
Oh, okay. Yes. Okay. Thank you. Anybody else who wants to share their upcoming webinars? I know PNA San Diego is having one too.
Yes, September 13 and October 3rd.
Okay. Yeah.
Dr. Twazan is one of our speakers on bylaws.
I look forward to that.
Yeah.
I also want to mention that, people don't really mention that people need mental health support during this time, because of the fears that they're experiencing. And I just feel like there should be, counselors available to speak to people that are concerned about, COVID and the effects that they've had on family. I know recently, like really recently, a couple of days ago, I found out that my mom's cousin, one of my titos in the Philippines, just passed away, from COVID. His whole family was infected with COVID. And unfortunately, I mean, he was vaccinated with J&J, but he also has other health issues. He's not the healthiest, and it's really taking a toll on everyone's mental health. So I think it's also important to recognize that, people need, some sort of counseling or some sort of mental health, help, with the things that are going on, with COVID.
Yeah, actually, Kat, just so to share with everyone too, the PNAA with its Kabalikat program and Heal the Nurses campaign had this peer-to-peer support group. We've had facilitators and trainers who would be doing so in each of the different chapters across the country. And PNAMDC is one, strong advocate for having one own chapter. And we actually have our own psych mental health nurse practitioner as a member who'd be leading this peer-to-peer support group. So we do really recognize that mental health among our nurses and on the larger community is essential as we navigate the new normal through, what we are dealing with, the fourth surge of COVID. So it's for the long haul. We're there for each other. And I, do appreciate the leadership of PNAA under President Mary Joy Dia, who really is very, focused on having this resiliency programs available for nurses across the country.
Thank you.
Well, one thing that we also need to be aware of is for people that have COVID, especially our nurses, because of the backlash, some do not want to share that information.
Mm-hmm.
They're hesitant to say. And in fact, personally, I know someone that reached out to me and told me, please don't share with everyone. And I think they need that kind of support, as what Kat had mentioned, right? So we need to also think about those pocket of population who are hesitant to come forward and say that they had COVID.
Yeah, that's true.
Well, I did share mine, except I didn't even know when I got COVID because I wasn't so sick. But then the only time I found out, my doctor said I was on my annual physical, and he said, "Oh, did you get the COVID vaccine?" And I said, "No," because when I was scheduled for it, I was sick, and it wasn't the really sick when I had my asthma attack or bronchitis or pneumonia. So he tested me and I have positive antibodies. I have the IgG, but I did not have the IgM. So he said, when did I have the COVID? And I said, I don't know. I can't remember. So now, and that shows that we don't know when we're going to get it. So it's better to be protected and be vaccinated. So I did have the vaccine. Thank you.
Yay.
It's lunchtime yet?
I was gonna say, are you guys hungry? Because I'm
Where's,
hungry.
where's the line?
Okay. All right. I know everybody has, at least you have half of the afternoon to enjoy your Saturday weekend.
Yes.
Thank
Thank
you
you so
again.
much.
Thank you.
Bye.
Thank you,
Bye-bye.
everyone.
Thank
Thank you.
Thank you.
Bye, Luz.
Bye. Stop.
Hi, Pearly. I'll see you in October.
Hey, yeah, October 9.
Okay. Yes.
Yeah,
Yeah.
October 8th. I'll see you. Bye.
Hi, Luz.
Thank you, Carol. Thank you for the invitation and the reminder.
You're welcome, Luz. Thank you for joining us. Waking up early. Yeah, waking up early for us. Thank you.
Yeah, we are setting up a day for our PNACCs, and we can just show the Facebook
Yeah.
streamline. Thank you.
Excellent.
Thank you, Ida.
you. Oh, you're welcome.
you,
Thank
thank
you.
you.
Thank you too. Thank you for attending.
Okay, lunchtime will be at the other end, other room.
I'll be there.
Okay.
Okay, bye-bye. Bye.
We have lechon
Bye,
and
Jean.
pancit over there. Yeah.
I'll be there.
Bye.
Okay.